Okay, so I think we can slowly get started. So welcome everybody to today's November edition of the CMR Journal Club. I'm Matthias Friedrich and currently actually calling in from the Mediterranean Sea. I'm currently a visiting professor in Rome, and I'm currently on my way in Italy back to Rome. And but that should hopefully not disconnect. I may have to switch off my video for. So it's really to me a very special journal club today because we have one of these papers that we want to highlight, especially because we think that they have a special relevance and importance. And this one, I think, is a great example because it uses the unique ability of cardiac MR to perform tissue characterization. No other technique can do that nearly as well, and does it in a disease where this is highly relevant, this is sarcoid. And then on top of that, I think this paper published in the New England Journal just a few weeks ago also does something, or the study does something which I think is so important, not just looking at images. Are they beautiful? Are they accurate? Are they precise? Are they efficient? But also, do they have an impact on outcomes? Because the best imaging modality will not help if its use does not improve the outcome of our patients. And this is exactly what this paper did, and I'm very pleased to welcome Harold Matthijssen and Chetan Shinoy to present their paper on predicting with respect to patients with suspected cardiac sarcoidosis. So thank you for joining, Harold and Chetan. And Harold, the floor is yours. If you could just share your screen and walk us through your paper.
Yeah. Okay. Yeah. Good afternoon and good morning, everyone. I hope everybody sees my screen right now. Yeah, perfect.
Yes.
So, yeah, thank you a lot for the invitation. And it's a great honor to discuss our previously published paper on the prediction of ventricular arrhythmias in patients with suspected cardiac sarcoid, and especially the usage of cardiac MRI phenotyping. This was a collaboration between 3 centers. Of course, everything was, the groundwork was laid by Professor Chetan Shinoy from the University of Minnesota. And he was the one who started with the cardiac MRI phenotyping in patients with suspected cardiac sarcoid. And this is a multi-center study to further investigate its usage and a comparison with current societal recommendations. So it was a collaboration between, of course, the University of Minnesota, the St. Antonius Hospital in the Netherlands, and of course, the Montefiore Medical Center in the Bronx, New York. So what we did in this study is that we investigated patients with suspected cardiac sarcoid, so patients with biopsy-proven sarcoidosis, extracardiac or cardiac, who underwent a cardiac MRI, and we further investigated its usage, and we used it to predict ventricular arrhythmias, so we can hopefully recommend which patients need a primary prevention ICD. So I'll just walk through the paper. Of course, hopefully everybody knows that cardiac sarcoidosis is associated with substantial morbidity and, of course, mortality. And we see a lot of life-threatening ventricular arrhythmias and, of course, also sudden cardiac death. So therefore, we need to risk stratify these patients. But we have, for so far, it has been very difficult to risk stratify these patients. We know that LGE on cardiac MRI plays a very important role, as we have seen from different meta-analysis and retrospective cohort studies. But still, those are small studies. And as LGE is also very important for the diagnosis of cardiac sarcoid, it makes it difficult to use LGE also for risk stratification. And so today, what we've seen, there are 3 different consensus statements or guidelines that recommend the implementation of an ICD for primary prevention in patients with cardiac sarcoid. First one is the Heart Rhythm Society 2014 statement, We have the 2017 American guidelines and the 2022 ESC guidelines. And there are some similarities, of course, secondary prevention and patients with an left ventricular ejection fraction below 35%. There are also some differences, and especially regarding the usage of LGE on cardiac MRI. For example, the 2017 American guidelines recommend an IFE. It's a class 2A recommendation for patients with cardiac sarcoids, an ejection fraction above 35%, and any or extensive, without further defining, extensive myocardial scar on cardiac MRI. While the European guidelines talk about significant LGE on cardiac MRI without further defining what is significant LGE. The HRS statement doesn't mention LGE, but they talk about ejection fraction. For example, they have in the societal recommendation class 2B for an LVEF between 36 and 49%. So you should, of course, consider an ICD. The problem with those current recommendation schemes are that patients with cardiac sarcoid, it's difficult to diagnose cardiac sarcoid. Of course, it's binary. Patients either have cardiac sarcoid or don't have cardiac sarcoid according to the guideline. But in reality, it's difficult. For example, the mostly used diagnostic criteria are the ones from the Heart Rhythm Society. And if patients, of course, have granulomas in the heart proven by biopsy, you have a definite diagnosis of cardiac sarcoid. But in many patients, it's more a probable diagnosis. So you think they have it, but you can't be 100% certain. So it makes it difficult whether these patients truly have cardiac sarcoid and deserve an ICD according to the current guidelines. So we try to bypass this by including only patients with biopsy-proven sarcoidosis, so either cardiac or extracardiac, who underwent a cardiac MRI, which, is even more practical to use in day-to-day practice. So what we did is we studied like consecutive patients, histologically supported sarcoidosis, who underwent cardiac MRI with late gadolinium enhancement in the three centers I mentioned before, between 2004 and 2022. Cardiac MRI was done due to suspected symptoms or electrocardiographic abnormalities. It wasn't really further defined, but all these CMR images were de-identified and were electronically transferred to the core laboratory, which was at the University of Minnesota, and of course, were interpreted by Dr. Shinoy and his colleagues. Most of these were done on clinical 1.5 Tesla scanners, and of course included CMR images and LGE imaging. Analysis was performed by two CMR experts, with disagreements resolved with discussion and consensus, as was briefly described in previous papers, because cardiac MRI phenotyping was introduced by Professor Shinoy and his colleagues in previous papers, including the one I highly recommend reading it in the JAMA Cardiology. LGE was visually identified, but was afterwards semi-quantitatively assessed on a 17-segmental basis on a 5-point scale, with 0 as no LGE and 100% and 4 as 100%. And the global extent was assessed as a percentage of the left ventricular myocardium. And then, of course, the most important thing, what's cardiac MRI phenotyping? Well, based on the previous papers by Professor Shinoy, we classify patients into 4 different phenotypes based on LGE features and left ventricular ejection fraction. So we have patients with pathology-frequent LGE that have at least one of 4 features, which is subepicardial, multifocal, septal, and right ventricular free wall involvement, which was based on previous findings, a systemic analysis of published gross pathology photographs of the hearts of patients with histologically confirmed cardiac sarcoidosis. So patients with definite cardiac sarcoidosis, where was it located? And that was translated to LGE findings. Then, of course, we have patients with LGE which don't include one of those 4 features, so those are classified as pathology rare LGE. And we also have patients with normal LVEF or impaired LVEF, but that was not included in the high risk or low risk features. So patients with pathology frequent LGE were the sole group of high risk patients, and we have patients in the low risk group that don't have any LGE or only have pathology rare LGE. All these patients were followed for a composite of sudden cardiac death, of course, document VT and VF, and significant ventricular arrhythmias, and that was censored for orthotopic heart transplantation death or the end of follow-up. And all those data was assessed blinded to CMR findings. Then, of course, we looked at the current guidelines, which I mentioned earlier. One thing I should mention, because extensive scar was not further defined in the American guidelines, we use a threshold of 5.7%, which has been a threshold found in earlier studies. And the European guidelines mentioned in the text that an LG affecting more than 22% of the left ventricular mass has been associated with arrhythmic endpoints. So we also use that threshold in the comparison with the European guidelines. So in the we use the 2014 HRS statement, the American guidelines including any LG, the American guidelines including LG with a threshold of 5.7%, the European guidelines with LG above 5.7% and above 22%. So 5 different groups. When we look at the results, we included a very large number of patients. So almost a little bit above 1,500 patients were eligible for primary prevention ICD. We excluded all the patients with previous ventricular arrhythmias because they already have an indication for an ICD. Of those patients, 26 had abnormal LVEF, 27 had LGE, and the high-risk phenotype was seen in 18%, so almost 1 in 5. And remarkably, there was even between the different participating centers, so 18.2% at the St. Antonius Hospital, 17.5% at the University of Minnesota, and 18.3% also in New York. So when we look at the most important thing, of course, the arrhythmic outcome, at a median follow-up of 4.5 years, 84% patients reached the arrhythmic outcome. There were also 6 heart transplantations and 142 deaths of non-sudden cardiac cause. And what we see is that patients with a high-risk cardiac MRI phenotype had significantly greater arrhythmic outcomes than those with a low-risk profile. And when we compare with the different schemes, we see that it was the highest for cardiac MRI phenotyping. And I think it's best seen at the key figure. Let's see, it's a little bit further. It's all at the beginning. We see it in the central illustration. You can see the prevalence of the outcome. Let me zoom that in a little bit. So we see, based on cardiac MRI phenotyping, 18% of patients had an indication for an ICD, and of those patients, 24% reached the arrhythmic outcome in 5 years, and 35% reached the arrhythmic outcome in 10 years. And when we look at the number of patients who don't need an ICD according to cardiac MRI phenotyping, it's 82%. Those numbers are really low. So a 5-year incidence of 0.7% and a 10-year incidence of 2.6%, which is, these results are truly amazing. Also, when we look at the area under curve, it's the highest for cardiac MRI phenotyping when we look at the different guideline recommendations, which for both 5-year and 10-year. What we can see, of course, it's in 10 years, the numbers are bigger also in the group who don't have an indication for an ICD. So one could argue that the durability of CMR phenotyping is at least 5 years, but perhaps 10 years is a little bit too much, and you should repeat cardiac MRI after 5 years to perform phenotyping one more time. So there are a lot of more results, but when I look at the time, I'm already past my 10 minutes. So the strength of the studies was, of course, there are a large number of patients included. We have a very long follow-up, more than 4 years, and the results are comparable between the 3 centers. And when we look at the comparison with the current guidelines, cardiac MRI phenotyping performs statistically significantly better with the other guideline recommendations. So I think, yeah, this is the most important results in our message, that cardiac MRI phenotyping can play a very big role in the risk stratification of patients with suspected cardiac sarcoidosis. And I think those are the most important points.
Yeah, thank you very much. Actually, the 10 minutes are only the rule if you have just one paper, but you have a featured paper. So there's also this commentary so maybe we can use this time to talk about, let's say, the surrounding aspects here. So first of all, congratulations. And this is really very helpful for clinical decision making. And it also repeats or confirms previous studies in other diseases where late gadolinium enhancement turns out to be more predictive of events and also deterioration of the clinical appearance. So do you want to comment on this commentary briefly before we dive into questions and discussion?
Yeah, of course. So we received a committee of the group of Dr. Kuparu and Dr. Poihonen from Finland, and they were wondering whether patients with only one feature, only one high risk feature, also have the same high incidence of ventricular arrhythmia, which is the case. So what we did, we also did a further analysis. When we look at this, let's see. Here it is. So we still have all our patients with one high-risk feature still have an incidence of more of, I think was above 10%, but I'll look at Chetan right now. Do you still have the numbers in your head?
Yeah, it's right on the left.
Yeah.
So 7.8% at 5 years and 16.8%. Yeah.
So patients with only a single high risk phenotypic feature.
Okay. So we have, since a few years, since the first paper published in hypertrophic cardiomyopathy indicating the 15%, I think it was from Marin's group, and then later on a meta-analysis showed that maybe 10%. I find it difficult to have a binary decision tree here saying, okay, it's 8%, so no, this is low risk, then 11%, no, it's high risk. But of course, at some point we need some guidance. So, but the problem I'm also having with using a percentage, and you did not to assess that as well. So I was wondering what your thoughts are. At the end of the day, the total amount of late gadolinium enhancement is probably less important than the transition zone between normal and abnormal tissue, because this is, I think, where arrhythmia happens. We have high mechanical stress down to a cellular or fibrillar level, and we may have unidirectional blocks of basically the electrically active fibers that may allow for re-entry circuits. So that's why eyeing always on the percent, to me, always seemed a little bit courageous, if not short-sighted. So I wonder what your thoughts are on that in sarcoid.
Yeah, I agree with that. The thing is, of course, with a percentage, an LGE percentage of the LV mass, it's very dependent of the person who interprets the MRI. It's dependent on the software package used. It's dependent on the method you use to define LGE. And it's also really difficult to determine the LGE extent. Some groups use the technique we've used so far as well. Others use tracings or stuff like that. And the good thing about cardiac MRI phenotyping that's it's really easily applicable. So you can just determine those 4 features. If one of those is present, patients are at high risk for ventricular arrhythmias and perhaps deserve a primary prevention ICD. But I don't think that LGE as percentage of LV mass should be used in daily practice because it's so variable. But of course, Professor Schnoy also has his opinion on that.
Yeah, so I think there's a difference between the HCM literature and this cardiac sarcoid literature. I think the bigger issue that we are facing with cardiac sarcoid is even identifying who really has the disease. And so remember, these 1,500 patients, they don't all have cardiac sarcoid. They were suspected of having it, and they had a CMR to investigate that. But we really believe that the phenotyping simply identifies and tells us who has cardiac sarcoidosis. And it turns out that this is so highly arrhythmogenic of a disease, of a cardiomyopathy, that if you have it, then you are at a high risk and you would benefit from an ICD. So I honestly believe that this 18% that had arrhythmias and have this high-risk phenotype are the only people who actually have cardiac sarcoidosis. And so this simply works by distinguishing between who has the condition and who doesn't. And
That's
yeah.
okay.
So with HCM, it's a different, everyone has HCM, and then it's a low incidence of arrhythmias. It's not an arrhythmogenic cardiomyopathy. In fact, if you take the whole group of HCM, the incidence of ventricular arrhythmias is very low. You need thousands to show a decent powered HCM study. But this is actually not that difficult. It's very arrhythmogenic if you have it. And what the phenotyping simply does is tell us who has it and who doesn't. And if you have it, you need an ICD.
So, okay. So you're saying it doesn't really matter how much scarring
Yes.
or infiltration there is. It doesn't matter how irregular it is.
Yes.
The moment you have sarcoidosis and
Yes.
you have late gadolinium enhancement,
Yes.
you should be considered high risk.
Yes. And in fact, if you don't have LGE, you don't have it. So we have shown that, and there's pathology studies. If you don't have any LGE, your outcome is excellent. You can confidently say you don't have cardiac sarcoidosis. And so every one of these has sarcoidosis in the body, extracardiac, but cardiac involvement is only based on the phenotyping.
Okay.
And that's
so the outcome, sorry, keep your thought, Harold. So the outcome you think would be the same between a control group and a patient with sarcoidosis, but no apparent cardiac involvement?
yeah, that's likely. Of course, you still have the group of patients who do show LGE but don't have any high risk features. And I think that's the most difficult group right now, because some are very reluctant to give these patients an ICD, which I obviously very agree.
So,
but still, do you need to treat those
yeah.
patients? What should you do with those patients? That's a difficult group.
Yeah. Okay, but now you're saying high-risk features. Chetan, you just said it doesn't really matter. So
Right.
How can we?
Yes. So, I mean, so we cannot prove that those who don't have the high-risk phenotype don't have cardiac sarcoidosis. And that's why we are presenting the outcomes, because we cannot really prove that those who don't have the high-risk phenotype don't have it. And in fact, the people who have the LGE but don't fit into the high risk, I think they have other reasons to have LGE. So mid-wall, I think it's hypertensive. Some of them have hypertrophic cardiomyopathy. I mean, you can have pulmonary sarcoid and you can have something else in the heart. And so it is low risk because they don't have cardiac sarcoidosis. And that 0.7% at 5 years is because they have something else. Some of them have something else.
Okay, understood. So, okay. So everybody who has cardiac sarcoid, should be considered high risk. And we know that patients with sarcoidosis, 50% of them die because of cardiac and not because of other reasons. So late gadolinium enhancement would be, the person of late gadolinium enhancement would be number one. the verification that this is sarcoidosis period. And number two, by definition, then they are considered high risk. Is that correct?
Yeah, yeah.
Okay, so we have a question from Dana Peters. What about risk stratifying within the cardiac sarcoidosis population so that you look, that was also what I thought.
Yes.
Yeah, that's difficult. Yeah, of course. How do you define your cardiac sarcoidosis population?
Yes, excellent question. And I guess that would be the next step in this work, where we look at this high-risk phenotype, which has like a 24% arrhythmic risk at 5 years, and try to see if we can refine it further. And there are many other newer modalities for refining it. I mean, this is very crude. This is simply looking at LGE patterns, which we have been doing for many years. But now we can look at things like radiomics. We can incorporate FDG PET. Maybe we can incorporate AI ECG, or look into the features of the LGE more than simply the pattern. So there is hope to refine this further, where we can identify an even higher risk group. And maybe we can identify a subgroup in this high risk phenotype where they do have cardiac sarcoid, but maybe they don't need an ICD. That there's hope in the future, but at the same time, clinically, at 24% arrhythmic risk, sudden cardiac risk at 5 years is very high. I mean, right now in ischemic cardiomyopathy, we see 5 to 10% among those who get an ICD. So this is clinically, I mean, we should do this. Obviously, we should continue more research on refining this.
Yeah. Okay. So now that you have looked at thousands of cases, anything you've learned in terms of the pattern? So I tell the people I'm training, look, in sarcoid, you can have everything. And it's very likely if you have a mix of subendocardial, subepicardial, intramural, and transmural infiltration. So is there anything you would recommend modifying that?
Yeah, so this whole thing, it's actually based, I mean, it's multiple papers, and we started out by a pathology review. We looked at published pathology cases, and we systematically reviewed the patterns, and we have described that. It's a JAHA paper in 2019. And if you download the PDF, we included every single pathology image illustrating the patterns. And so at some level, this is like human intelligence. We do a lot of AI, but here we simply looked at all the images and visually we said, what does it look like? What are the common patterns and what are the rare things we never find? And so I would encourage all trainees, everyone, to look at that JAHA paper for the pathology images. You can look at it yourself and reach the conclusions we reached. And that's how we found these 4 phenotypic features, which we found in virtually all of them. And then, there were other things like isolated subendocardial or isolated mid-wall LGE, which we never found, which we never saw. And so if you see that, you can exclude cardiac sarcoidosis because it's rare. And so I would encourage looking at that PDF. Download the PDF. It's about 60 megabytes because we have included 50 of the pathology, gross pathology images of the hearts, which is exactly like LGE images. You can see the cardiac damage, which is exactly what we see on LGE imaging.
Oh, you're muted, Matthias.
Oh, sorry. Thank you very much. So are there any other questions from anybody regarding that? So with that, if not, I want to thank you again, Harold and Chetan. You have really produced a study that is very relevant. It's a lot to learn for us, and also I think with important impact on the outcome of people who may never know your names, but who should be grateful that you did that study. Thank you again, everybody. Nicole Sabale could not join today. She will write an email, send out an email with the articles that will be discussed in the December edition. Until then, again, I want to thank Harold and Sheldon for their participation, and I wish you all the best, and see you next time. Bye-bye.
Thank you for having me,
Bye-bye.
and thank you, everyone.
Yeah. Bye.
Bye-bye.